Hey everyone, this is Soph, and you're listening to the Beyond Pain and Fatigue podcast, where together we'll explore the complexity of chronic pain, fatigue, and invisible illnesses. Today, I am very pleased to welcome Dr. Jason Lam, a former professional dancer and artist and a neurodivergent philomath, which is Greek for lover of learning or scholar, for those of you that haven't heard that word before. Jason pivoted to medicine after a collapsed lung, and subsequent Scrubs marathon made it seem like a good idea. He describes himself as a less pathologic Dr. House, specialising in complex diagnostic challenges, including Ehlers-Danlos syndrome, MCAS, ME/CFS and dysautonomia, as well as sports medicine and minor surgery. He's a member of the Australian EDS and HSD network and sits on the scientific advisory board of the CTD-NA. I had the pleasure of meeting Jason for the first time earlier this year when we co-presented at the Global EDS conference, and I'm very, very excited to have him on for a discussion. So thank you so much for joining us, Jason.
Thanks so much for having me. Yeah, it's just a fancy way of saying I have a short attention span and have collected too many hobbies.
I feel like there's a lot of people who could probably relate to that working in this field, and we're very glad that you've decided to take that path. Thank you. I guess, Jace, I know I've just introduced you a little bit, but I wonder to start with, would you be happy to maybe share a little bit more about yourself and maybe your work and I guess what that looks like for you on more of a day-to-day?
So I work, officially my letters are GP, so I've got my fellowship at the Royal Australian College of General Practice. I'm also doing a second fellowship in sports medicine, and yeah, my days are usually kind of spent doing this sort of stuff. Probably about 3/4 is going to be kind of diagnostics, opinion, and then I still like doing my procedural sort of stuff. So I like doing minor surgery, doing skin cancers, and foreign bodies and ingrown toenails, and also really like my ultrasound. So I often use that to fish out implanons which have gotten lost, or popping in cannulas for people with tricky veins. Yeah, so that probably takes up the other bit. I do a little bit of surgical assisting as well.
Yeah, fantastic. And it sounds like, you were a dancer and sort of very much work, I guess, had exposure in that sort of sports dance space. But I'm interested, what sort of led you on your path to working in this sort of more complex space of hypermobility disorders and all of the things that go hand in hand with that?
I mean, a few things, I guess. I can't let things go. So, I was just seeing patients that I couldn't quite work out what was going on. And so, kind of just kept digging into that, because I've got that connection with dance. So a lot of people who are just baseline hypermobile anyway. And, like we talked about at the conference, hypermobility can be adaptive. It can be an advantage. So many of our elite athletes actually are hypermobile, and everything's fine while they're, in tip-top shape. But, they retire or they get sick, they get an injury. And then everything comes a cropper and they get the same stuff sort of thing. So, I started seeing that pattern there. I was already doing that. And you know how it is, you help someone and then they tell someone else, and then it kind of snowballs from there. But then also I had some personal experience where, I retired from dance because I spontaneously collapsed a lung. And then I got a septic shock a couple of years ago. And that really kind of triggered off my own kind of hypermobility, MCAS, ME/CFS, post-sepsis sort of stuff. Yeah, so that gave me a bit more kind of personal experience of it. 0 stars, don't recommend. And then, I was lucky enough to do a couple of presentations, just kind of builds from there. And I guess the more you see, the kind of more accustomed you are to it.
It does kind of seem to, at least from my experience working in a very similar space, although admittedly from very different sort of perspectives. I guess me as a physio compared to medical is quite different. But I think the thing that I've often felt is like when it comes to hypermobility disorders and EDS and all of these related conditions, they kind of do feel like things that like once you see them, you can't unsee them. I had this reflection when I was kind of looking back on my own practice and sort of realizing how many people I was probably seeing earlier on in my career that had these things, but just I didn't, I wasn't aware at the time. I mean, our training doesn't really include much at all about these sort of conditions. So, I couldn't have necessarily known any better, but in hindsight, definitely, I think we probably see more than what we pick up. What was it like for you? Do you feel like, I guess these conditions, are they conditions that are talked much about from your experience with your own medical training?
No. Unfortunately, we kind of cover some of like the big monogenetic kind of connective tissue diseases. So Marfan's, you might get a bit of osteogenesis imperfecta sort of thing, but not the more common garden variety sort of thing. And it's an artifact of our medical school, I guess, it prioritizes hospital medicine.
Mm.
And it also prioritizes and valorizes hyperspeciality.
Mm.
That's who we looked up to. That's who taught us. So so I think that was a big thing missing, is kind of that tying everything together. Yeah, we're not a bunch of independent organ systems walking around with a brain floating nearby, but that's kind of how we treat it. The psychiatry was off by itself. I mean, gastro didn't talk to cardio, so everyone did different. Like, we had amazing teachers, but yeah, hyper specialists. Like, I mean, the guy who taught gastroenterology was a world leader in the myenteric plexus, which is super cool. Arguably, maybe not a holistic picture of health.
Mm.
So I think that's an artifact of it. And then, I guess, medical misogyny definitely plays a role. Vast majority of our patients are female, or assigned female at birth. And much to our detriment and shame, I guess, we were kind of taught, if you couldn't find anything, then it's probably anxiety. That was like the default. Is like, if you can't find something, then it's functional, or it's anxiety, or psychosomatic, or something like that. And so there was a bit of, I guess, neglect in there. There is an arrogance that we do get kind of taught and bred. It's like, I don't know about it, then it can't be a thing. A pretty dumb way to look at it, considering the vastness and complexity that's involved. I guess, like MCAS, like, look, there still isn't a definition for it. It's still not accepted by the major allergy bodies. And, and then this also becomes a part of what can you measure? And we know, say, MCAS is very difficult to measure. So these things make it really hard because, the diagnostic criteria are vague, they're not defined, not agreed upon, they're difficult to do. Or, as in the case of many of these, is like they're so heterogeneous, experience of it and symptomatology is so different. So that makes it really hard to do a study. Like, our gold standard is massive RCTs. But how are you going to find 10,000 people with the same picture? That makes it really difficult. So I think it's a bit challenging. It's not really discussed. I'm heartened by the interest we've had. I just presented up at Gold Coast to the sports physicians, and that was awesome. That was super well received. We did the MCAS thingy with Larry Afrin up in Sydney, and with Bianca, who's the lead of our CNE. And just fantastic interest. So I think it's growing, but long way to go yet. But really glad to see that there's some recognition.
Absolutely. And I think all the things you've mentioned there, particularly around experiences of, missed diagnosis or sort of having things written off as psychological, I think that's definitely something that I've seen on my end, often from patients who have been trying to navigate that journey. And it is really tricky because people do present very differently. I feel like there are so many different topics that I could pick your brain about. I would happily keep you hostage here for hours and hours to do so. But I think one of the things that we do see coming up a lot, quite topically, like you said, MCAS in particular is something that, we're starting to get a little bit more sort of awareness and discussion around, like sort of, I guess, that mast cell activation syndrome, but also even sort of histamine sensitivity more generally, and I guess some of these sort of overlapping issues. I've certainly seen that these have been coming up more and more in discussions and for patients that I've been working with. And I think you'd be a great person to chat more about that with. I guess it seems like these are things that you see quite a lot in your own practice. I wonder, for someone who might be listening who hasn't sort of come across these conditions, or even as a GP, how would you sort of explain mast cell activation syndrome or histamine intolerance to patients?
So I guess mast cell activation syndrome, first we've got to remember what a mast cell is, which I think we got 15 minutes during immunology in med school. So it's a very primitive immune cell. There's no condition that I know of where you can actually survive without mast cells. And they're kind of found in like sea squirts. So it's a very primitive part of the immune system. And I kind of can think of them almost like a guard dog. So they kind of hang out. They're your first line. They hang out at the interface between you and the world. And their job is, if something dangerous comes, is to try and slow it down. So they have all these preformed mediators like histamine and tryptase and all that. You can imagine they have lots of little hand grenades that they can just go boop. And so they bark. They make a lot of noise. They try and put some inflammation up, try and slow down the danger. And then they can also call in, the specialized immune system. They can call in SEAL Team 6, so they can They've got other mediators that they can kind of make themselves on the fly. And there's all these chemokines, cytokines to get other cells to kind of get involved. So there's, I think, around 1,200 mediators that mast cells are responsible for, the most famous being histamine and tryptase. But they also have a whole bunch of other stuff which makes, vasculature dilate or get leaky, other inflammatory leukotrienes and prostaglandins and all sorts of stuff. So so they live kind of very much in the skin, in the mucosal surfaces, respiratory, gastrointestinal, basically between you and the world, but they also hang out next to nerves and blood vessels. So they've got a really far-reaching effect. And that's kind of the tricky thing with it, is that they are pervasive across essentially every vascularized tissue bed. So they can be involved in anything, and they've got receptors for everything. So they've got pressure, they've got cortisol, they've got estrogen, they've got temperature, vibration, like you name it, they've got it. And so the theory is that you get this population of them which have a mutation which makes them, for want of a better word, easily triggered. So they will drop their bundle at less provocation. And so that can kind of be anywhere. And then they can drop their bundle, and then that can travel through your vasculature and activate another bunch. And so the bummer of it is they can also activate themselves. So they've got receptors to their own things that they release. So they can kind of kick themselves along. So this probably goes in a part to explain why they can have such a vast range of presentations. Whereas with histamine intolerance, I guess that's more of a deficiency in a particular enzyme that breaks down histamine. So histamine is a natural part of your immune system, but some people have difficulty with basically breaking that down, so it persists longer. So I guess if you use the bucket analogy, so there's like the idea that you've got a bucket and you can have a certain amount of histamine or mediators. So with MCAS, you've got stuff you just go, and there's too much. It's overflowing because you're producing too much of the mediators. Histamine intolerance is the little drain down the bottom is clogged, so it can't process that, I guess. A little bit more complicated. That MCAS probably involves a lot more mediators, so like 1,200 or so mediators. I haven't bothered.
Well, it sounds like, and please, this is my very non-medical understanding. People might have, say, mast cell activation, so they're getting that overproduction of histamine, and they can also have histamine intolerance, where they're also having difficulty with the actual clearing. But you can also have them kind of in isolation as well. So you might have one or both, and how you might sort of address that might vary depending on what's actually going on for that person.
You probably treat it a little bit similarly, so part of the management of MCAS is to, avoid triggers. So we know that high histamine is going to be a trigger. So if you've got your bucket and you've got these active mast cells, if you keep pouring extra histamine in by the way of aged cheeses or fermented foods or that sort of thing, it's just going to fill up quicker. Trying to modify that. You could also, for patients who do find that, something like a DAO enzyme, so you could possibly consider that like Drano. So we're going to help you clear some of that a bit quicker. And then, our first line of treatment for MCAS is going to be the antihistamines. So they're going to help with kind of blocking histamine.
It's interesting because, we've sort of already touched on that there is so much overlap between a lot of the conditions we might see co-presenting with MCAS. It seems like there's a lot of different conditions that mast cells have sort of been kind of tied up in. I mean, I'm sure that, you would know more about this or be more across this than I, but, I've heard mast cells be sort of discussed in association with things like fibromyalgia, like ME/CFS, long COVID, a lot of other sort of pain conditions have sort of, explored that area a little bit. And it does seem like there's a link there with hypermobility as well. Do you think, I guess from your perspective, and I guess in some ways where maybe taking a bit of a guess, because the research I think probably isn't quite there yet to help us work this out definitively, but when you sort of see the mast cells kind of being implicated in a lot of these conditions, do you think is that sort of why we might see that there's a lot of symptom overlap between some of these conditions, do you think?
It's a big question. Yeah, maybe. I think there's lots of different phenotypes. So I think there's lots of, there's a bit of argument. It depends who you talk to. So everyone who has their kind of pet thing, the hypermobility crew tends to think that is your dodgy connective tissue, which disturbs the mast cells. Mast cell crew thinks it's the mast cells making your connective tissue dodgy. The mast cell crew thinks that it's your mast cells which make POTS, or which drives POTS because they vasodilate. And then the hypermobility crew is like, no, your collagen sucks, so it kind of doesn't compress. So I don't know. We know that there's a lot of overlap. I do see people who have one and not much or none of the other. So I think that is certainly a possibility. And so that's kind of the tricky thing, is kind of it's finding out what exactly is their particular flavor, what is most prominent on them, and then trying to work with that. I mean, there's also some stuff, I guess, like hypermobility. To be honest, there's not much you can do for it from a medical standpoint. That's where we hand over to you guys. Definitely, if I see one, I'll assess for the others. The trifecta or the pentad or the whatever, kind of however big you want your Venn diagram to get. But yeah, definitely have a look at it. Because they certainly do seem to like traveling together, and I'm not clever enough to know what the underlying cause is. I mean, there was a recent papers out on the hypermobile EDS which looked at, I think there was a zinc transporter and another SMP, or some sort of like pro-inflammatory scavenger. Does that cause effect?
Always so tricky because, even looking at some of the pro-inflammatory shifts that we see in some of these conditions we've already spoken about, even then looking at some of the broader pain research, for example, they're now showing that, potentially a lot of persistent pain states and sort of, I guess, the vulnerability to developing persistent pain and symptoms of persistent pain often also present with, some of these sort of immune and nervous system changes as well. So it's, I find it really fascinating, I think, from where I sit, because I'm very much coming from the pain science space, obviously general musc training, but I think it's been really interesting for me because it almost seems like there's all these, kind of like what you were saying before about the hyper specialization. I think we see it in the research too, where it's like all these little camps of research happening, and then it's kind of like, but people actually are kind of existing in the middle, and we just kind of need to be able to bring all these bits together in a way that makes sense. And at the moment, it seems like that's mostly happening, I guess on the cliff face, like, with yourself and other clinicians who are kind of working in that space.
I'm not clever enough to have a grand unifying theory. I'm a bit of a pragmatist. So it's basically, I'm very good at whack-a-mole. That's kind of how it works. Because, we don't know what's the underlying, there's no root cause sort of thing that we know of that we can kind of directly target. If we did, great. We'd love to go for it, but we don't. Just in terms of, other things mast cells are, the recently papers showing mast cells hanging out next to trigeminal nerves, so possibly migraines and trigeminal cephalgias, endometriosis, lipedema, inflammatory arthritis, even osteoarthritis. So, I think there's also, a very strong link with neurodivergence. So where does that fit in with that? So there's the CCX gene theory, which I'm not an expert on, but it's a cluster of genes and they seem to have susceptibility for all of these things. That's if I was going to bet, I'd probably bet on something like that there's a cluster of susceptibility genes which can have environmental triggers, and then they can manifest in lots of different ways. Because we do see that people, and I'm an example, like these things can change over life. I got more flexible after sepsis. I got more hypermobile after sepsis, despite getting older and crumblier. I'm bendier. So these things can be changed through life events.
Just to clarify for anyone who is listening and maybe can't see Jason's not that old, just to preference. It's maybe possibly tangential to what we're talking about, but I find that piece interesting because another conversation I was having recently was actually with a couple of colleagues that I work with at UCLA over in the States, and they work out of the gender clinic there. And we were having a conversation about how we don't really know. There's some interesting sort of complexity that comes about, particularly when we are working with trans folk who are hypermobile, because the role of sex hormones has been shown to influence hypermobility. And often then if people say, for example, they might be assigned male at birth, but potentially start, gender affirming hormone therapy, then that might shift as well. So, definitely like in your case, there was a sort of an unusual sort of pattern when it came to age and how that mapped with some of these other things that were going on for you. But there's some really interesting sort of stuff also happening with the complexity of it in some of these other spaces too, which is...
Oh, absolutely. Yeah, perimenopause. So, for AFAB folk, perimenopause is often a big step change. Puberty can often be a big step change. So and then just straight up trauma. There's a bunch of people who were fine. They have a car accident and suddenly everything goes to heck. So I think we haven't found it yet, but I'm certain there's some sort of epigenetic switch, and some susceptibility. The Swiss cheese model kind of just knock that little bit off, and then all these things happen, and tricky to put the genie back in its bottle.
So you sort of, as you were explaining MCAS before, you sort of touched on the fact that, mast cells are within the connective tissue, and connective tissue is many different areas of the body, and, are often at that, particularly for mast cells, at the interface between us and the environment. And that's where they kind of do a lot of their work. For you clinically, like, I guess what might be the ways in which MCAS sort of shows up in the clinic, or if you're seeing someone, what might be some of those clues, I guess, that maybe there is a bit of an MCAS-y thing going on for them?
There's a questionnaire that's been published. It was in a gastroenterology paper a little while ago, which covers lots of symptoms and that sort of thing. But I mean, just pretty straightforward. I mean, hay fever is MCAS, really. Like, that's an overactivity of mast cells in your respiratory tract or your eyes, which make them water. But other things would be, dermatographia, where you can like touch your skin and it comes up, or like cold urticaria. So where you get typical mast cell mediated reactions to things. So they're probably the easy ones. Like, some of the other ones are the ones which, the people who seem allergic to everything, smells, perfumes, just cause migraines and like this intense discomfort. I think that's mast cells in the upper respiratory tract, or perhaps the lower respiratory tract. Gastrointestinal is often a big one. So a classic eosinophilic esophagitis is probably MCAS of the esophagus. And then irritable bowel syndrome, which is kind of it's not much of a diagnosis, very just descriptive. But that's probably, at least some of them are going to be mast cell mediated. So they're kind of some of the things that can kind of clue you in. Sometimes people have remarkably good response to, say, antihistamines, kind of more than you would expect. That can be a clue. They're probably some of the more obviously sort of ones. Other weird ones with like, temperature or pressure. Some people get symptoms like with weather change, or like as they go up and down in the plane. So it's kind of the speed of the reaction is a bit of a clue, because there's not many things that can react that quickly. So
so it's kind of, it sounds like sort of that whole host of kind of allergic-y sort of symptoms that it might happen across different body systems. You might be kind of thinking along that line.
Kind of inflammatory type things. They don't necessarily have to be allergic-y. They could be like a inflammatory type picture which doesn't fit with something else.
And with the GI side of things as well, because you mentioned like a lot of IBS sort of symptoms, often go hand in hand with mast cell issues. This is where I guess something that I often see with patients, and I'd be interested to see if you see this as well. I guess people seem to report a lot of issues with just food intolerances as well as the broader external allergies and things. Just dietary wise, they seem to not be able to tolerate a lot of stuff. Do you see that a fair bit in your practice as well?
Yeah, absolutely. It's one of the things we actually try really hard to work against. I'm indebted to the dietitians who do all the heavy lifting. There's a bit of a tension, I guess, because one school of thought is to avoid triggers. So anything you react to, you just keep away from that, because you don't want to, if you're a tire, you don't want to poke more holes in the bucket. But at the same time, I think the histamine bucket has a lot to answer for. So like previously safe foods, which suddenly become unsafe. Did you truly have a problem with it, or was it that was just the last straw on that day? And that just pushed you over. And then one of the problems that we see is, as people restrict their diet more and more, then that buggers up your gut microbiome, which is going to bugger up that's going to make it more reactive. Right? How many points of different vegetables and plant foods are you supposed to have? I definitely don't hit it.
5 and 2, I think.
I think it's something like 38 different ones over the week or something.
Oh, sorry, I think it's, if you're talking weekly, I think it's like 50 a week or something. 50 different.
That's a lot. But so you're supposed to have this vast array of food for optimum gut health, and you see these people kind of just restrict, and so it ends up being a bit of a vicious sort of cycle. And then this compounds again often with gut dysfunction, so it doesn't move well, so they're like fecally loaded or constipated, and so you've got further things as insults to the gut, they're not supposed to be holding on to concreted poop all the time, and as they try and squish it out, that causes, the mechanoreceptors and pain, releasing serotonin and irritating mast cells. And, then you get those, Rebecca Ryan does a much better job of this, but you get signals going up and down to so sometimes people get that insta poop. So they have something to eat and then they have to poop instantly. That's kind of thought to be you're getting a bit of a signal and it kind of just causes a massive kind of wave through. It's not the food you ate, but it triggers a thing and they go back up the other way for nausea. So yeah, these become really troublesome. Because is it a structural constipation which is causing it, and it probably didn't matter what you ate. Yeah, so I rely very heavily on the dietitians to help me out.
We are planning. I've got an episode lined up in a couple of weeks where I'll be picking the brain of a dietitian about this sort of stuff.
Excellent, good. I should tune in and eat more vegetables. I should be.
You touched on a really nice point there, because I think what you described there about, for a lot of people, actually a lot of foods and a lot of triggers might actually be okay for most of their life, and then they sort of get set off and suddenly they're reacting to lots of things, and it does become this bit of a vicious cycle. I think the general, speaking very broadly and at a, I guess a big picture level, the general sort of impression I've gotten for how we sort of tend to approach this overall is kind of maybe minimizing or reducing some of that histamine load or the triggers in the short term to allow people to sort of stabilize a little bit, but then with the goal of trying to get things under control enough so that we can start to reintroduce and sort of get people back used to those triggers. Because it is, I mean, if for some people, certainly I think back to a few of the patients I've had where it's if we cut everything out that was triggering them, they would basically have to be in a small sterile room and not do anything, basically.
Yeah, we work really closely together. So, I think one of the early aims is to clear out any fecal loading so that, they've got a clear shot at least, so that, things are moving as best they can. We're not backed up. And interestingly, I found I haven't had to treat anyone with for SIBO, really. Once we get them kind of going and the diet improves, just haven't needed to do that nearly as much as kind of might have thought. And kind of, I guess my theory is if everything's still stuck, you can nuke it, but everything's still stuck. So they'll just kind of repopulate in the same dysfunctional sort of way. So, I would generally tend to aim for getting everything cleared out, moving. And then if they still have symptoms and stuff, then yeah, but then I think we're going into a more friendly environment for that. But yes, often I want to try and clear it out, start some MCAS treatment to try and give them that bit of buffer so that they can start reintroducing foods and improve the gut health and that sort of thing. So yeah, it's always a fine sort of balance, and there's always a bit of give and take, and try and I appreciate patients want certainty and that sort of thing, but there isn't any, unfortunately. And everyone's so different, so it'll be kind of that finding, well, what works best for you, and things will change. We know, and you talk about this way better than I do, but how much allostatic load impacts all of these things. You've got all these other stresses and pressures on the body and on the system. And the more of that, then you've got less capacity to do all the other things. So yeah, it's a really tricky. That's one of the challenges I'm trying to work out how to manage for patients who feel understandably overwhelmed. They just want a clear recipe. It's there isn't one. You try this and if that doesn't work, then we try this, and which is
Absolutely.
not as nice as you have torn an ACL, see a surgeon, rip off some hamstring, shove it in there or whatever.
Yeah. Do your rehab and
do your
off
rehab.
You go.
Your defined protocol with defined return to sport goals. That's relatively simple. There's a protocol for it. We kind of have a pretty good idea what's best practice for that sort of thing. Whereas with this stuff, we're kind of on a journey together to try and work out how that particular flavor, what's the best way to treat that.
Absolutely. And I guess from my perspective, while I'm certainly not the person who's sort of speaking to patients about, I guess, diagnosing and sort of the medical management side of these things, they are, mast cell activation issues are something that sort of come up or flag for us as part of our working with people. And one of the common challenges I hear from people is that these issues are often not particularly well understood in the general sort of health professional community, just because, I guess it isn't
I'm
really
not sure
part
I
of.
understand it well. So
Yeah, yeah, and that's it. And like we're interested, like I think there's that element of it being kind of not super well explored from I
mm,
guess a research management clinical guideline perspective, but there's also that added layer of just, I guess, the recognition or picking up of these conditions in
mm,
practice as well. And so I guess a question that I commonly get from patients when we're sort of starting to, if I see someone who maybe hasn't been diagnosed with mast cell issues, but they're presenting with all the things you're describing, and my brain sort of going, oh, this is sounding a bit, potentially MCAS-y. That obviously needs a further evaluation input from a GP or a medical, professional to kind of work this out. I guess diagnostically, I know that there are some challenges there. How do you approach sort of working out if someone's presenting in a way where you're thinking, okay, this sounds like it could be this? What does I guess the testing diagnosis process sort of look like for you?
depends a bit if you subscribe to consensus 1 or consensus 2, which are the two main kind of thoughts. To be honest, consensus 1 is pretty hard. That's the officially recognized one. So that is based on trip days, and you need a baseline and then an increase of 20% over baseline. It's really hard for our population because what's baseline? When are they feeling amazing? It's not quite the same as like anaphylaxis where it's like fine, trying to die. So that's really tricky. And the testing itself is also difficult. It's technically challenging. It's temperature sensitive, and you have to keep it away from light, I think, and you have to get it into the lab you need to test it within 4 hours of the peak.
Mm.
So all these sort of things, like, there are patients who go in with anaphylaxis into hospital who don't get a trip days. So yeah, it's tricky. So I still test for trip days because there are, so trip days is almost never elevated in MCAS as I guess we're talking about it. You do see elevated tryptase in something, there's a condition called hereditary alpha tryptosemia, which do see an elevated tryptase. It's pretty rare. And elevated tryptase is also seen in mastocytosis, so the clonal problem. So that's where you have more mast cells. MCAS is not more mast cells, it's more easily triggered mast cells. So I still do that as a screen. It's not particularly high yield. Then the problem is the other mediators of mast cells are very short-lived. Histamine has a ridiculously short half-life and is also temperature sensitive. So trying to get that, we face the same troubles. Larry Afrin quotes like a 30-second half-life, which is also temperature sensitive. So that's really hard. But I do urinary histamine. So you can do urinary histamine and its immediate metabolite 1-methylhistamine, which is a bit more stable. So you can try and do that. And I've picked up a couple with that. And then there's no other really easily accessible or validated test. So there's some talk about, I think it's the prostaglandins and leukotriene-4 and that sort of thing. They're just not available. And then I guess the other question is, those ones aren't recognized by the Consensus 1 crew. So do you need it?
Mm.
Because even if you had it, the Consensus 1 crew don't believe it's a thing. So you're not convincing them. I'm already probably convinced. I don't need it. So yeah, so it's a bit of a tension there. So yeah, I do. But yeah, I'll do tryptase and I'll do the urinary histamine. I generally also look for an IgE, total IgE, just a general allergic sort of burden. And then it's all the other differentials that you need to think of, because it could present so many ways. It could also be a whole bunch of other stuff. And that's, I guess, is it a worry? I guess, yeah, one of the challenges, because there's so many things it can present with, is working out the differentials of it. And it's one of the challenges I'm kind of seeing. So again, it's tension that doctors are wanting to be helpful. They want to be validating. And so they give the diagnosis and the treatment. And that's great. However, I've also come across a bunch of people where maybe they weren't worked up enough. And so other things were missed, kind of perhaps in the well-meaning kind of way of wanting to validate and treat. So I think that's a important thing to keep in mind. I also understand it, once you kind of learn about it, you kind of see it, you get really excited. It's like, oh my God, could this be MCAS? Could this be? And you kind of jump to that. But I think it's really important that you kind of take a step back and think about what else could it be, rule that out kind of systematically. The differentials are often much rarer. just like a pheochromocytoma or paraganglioma, much rarer. But also I feel, if you miss that, then you're kind of barking up the wrong tree again, you know. So it's tricky. Some people with POTS, which again, I think we need to emphasize, it's in the name. It describes what's happening. It doesn't tell you why. Their heart rate goes up when they stand up. There's lots of reasons why that could happen. So I've had a couple which were actually REDS, so relative energy deficiency in sport. They just weren't fueling enough, but it presented as POTS. So you could beat a block of the buggery out of them. It's not going to fix the problem. What they need is adequate fueling and revised training regime. I've had others which have had low cortisol. So again, we can do everything you want on the symptom management of POTS side, but if we don't get their cortisol back to some sort of physiological range, we're not going to win, So it's tricky. It's fun. That's kind of the fun of it. So it is one diagnosis and it's probably the elephant in the room, but I think it's also behoven to us to not get too fixated on that, keep our spidey sense open for something else that we should that we can do something about. So yeah, I don't have a set batch of tests. I kind of very much tailor it based on the consult and how that particular person presents. And that's kind of how I play it. And not uncommonly, we'll wake up in the middle of the night and be like, oh my God, I need to do that for that person.
I think it sort of sounds familiar to, I guess, how we're tending to approach things from a pain fatigue management idea. You mentioned the allostatic lows sort of idea before, where it's like you're sort of trying to assess and pick out when there are these sort of discrete aspects that do need specific management, or one person might present with these specific components of their presentation that you do want to address, because you're like, maybe there is specific things that we can do for that thing, or it's really important that we do manage that particular component. But we're kind of always then trying to zoom back out and kind of look at the big picture and go, what else is going on? And sometimes for some people, there might not be those really hyper specific things that we can pick up on a test, or, we can kind of rule a lot of those things out. There's still lots of things we can do, but it's important that like we've actually looked for those. And if they are there, that we're addressing them. So I think that kind of maps in some ways to, how we kind of approach the pain fatigue side of things.
Yeah, kind of go in, go out, just double checking yourself. I try to be aware of my own kind of cognitive biases and anchoring. I think that's a real danger for clinicians, is that kind of anchoring sort of thing is like, well, I thought it was this last time, and you just kind of just continue it. And I think we've got to be really open to the fact that, oh, maybe you got it wrong, or things change. A new piece of data comes out which refutes that or points in a different direction. I think we should be humble enough and unsure of ourselves enough that we pay attention to that and give it the due consideration. Maybe you were right. That was a random data point, but maybe that was the key, and it should have pushed you down a different path. Yeah, if they're not responding the way I expect them to, I'll kind of, go back to the drawing board. And also, like, if I can't work it out within a couple of visits, then I'm going to try and phone a friend. I think that's always the fun of diagnostic medicine. Always kind of keeping all the balls in the air. But obviously, yes, the competing thing is like, we also don't want to. There is also over testing. There's an error rate in every test. You do enough tests, you're going to get something positive. Now, is that going to be a true positive or false positive? So then having a good understanding of Bayesian sort of principles on what tests, how much weight do you put on it. So yeah, it's good fun. I bore my med students and regs with this all the time. But I think that's really the crux of clinical medicine, is that finding that kind of middle path. Yeah.
For sure. And you've sort of touched on things a little bit already, but if we were talking, I guess, big picture without getting like too in depth on each of the discrete components, because we really could be here forever talking about this. But I guess in terms of those big picture sort of things that you might be thinking management wise, if somebody does say test positive for MCAS, if they come back, or maybe they don't, maybe they're presenting with all of the signs and symptoms, but you've ruled other things out, but it's seeming like there is a mast cell sort of issue going on that could be contributing to symptoms. What are those major I guess, management sort of things in terms of the things that you might sort of look at starting people on, whether that's medication, but also, I guess, broader sort of input
Yeah.
management that you might be thinking?
Yeah, for sure. So actually, I totally forgot. So the big part of consensus too is, and kind of the crux of it is, they've got the pathology tests, but they recognized that not everyone can access them depending on where you are in the world. So it's like, it's pretty much a vibe. It's the castle sort of thing. So if it kind of feels like MCAS and you treat it with MCAS treatment and they feel better, that kind of is the consensus to diagnosis in a broad sort of thing. So yeah, so actually part of making the diagnosis can be starting them on treatment and seeing if they improve. So yeah, broadly what you got to do is you got to try and reduce the things that can provoke you. You want to try and ameliorate the effects of mast cell activation. So that's your antihistamines. And then you want to try and stabilize your mast cells. So there's a range of different medications which can try and do that. And there's also supplements. And there's also, we shouldn't underestimate the importance of all the allostatic load stuff. If you're in raging autistic burnout, that's probably not helping. If you've got massive stresses, you might not be able to do anything about it, but it's important to also consider the effect that might have. You're seeing more, I guess, in the perimenopausal space. So, if the hormones are all out of whack, maybe that's actually a key thing to try. Lots of different ways. Like I said, gut is often one of the ones which I very much focus on quite early, because generally I found if we don't get that sorted out, the other stuff doesn't work as well. A huge challenge is keeping your mind open to the divergence, because there's such a massive overlap, and if they would benefit from a diagnosis, that's to understand themselves from an autism point of view, or one of the things I do see is ADHD. And I feel for patients, because it's a lot. It's a lot to manage a chronic illness, and for some people with ADHD, and they've got or autism and ADHD, it can almost it's a relief to get a diagnosis, but then it's an overwhelm of, oh my God, there's 1,000 appointments and tests I need to do. How do I do that? And so there's a balance of trying to work out how to address that. So for some people, ADHD and executive dysfunction is a major barrier. And so actually getting that sorted out is key, because if they have so much difficulty with executive function that they can't take their medications, some of these medications are 4 times a day. If they can't do that, I'm not going to win. So that might be a really important sort of thing. For some people, for me, I guess, it's hard to see me. I'm also expensive. So I want to try and provide heaps of value. So my nature would be to be like, okay, here's all the things, go away and work it out, which works for some people, but also that's monstrously overwhelming. So I try and have a discussion. It's like, how do you want to do this? Because the thing is, I can't see you every week to kind of stepwise go through this. But would you feel better with we'll do a couple of things and we'll check in a month sort of thing? Or I'll try and enlist the help of some of my fabulous colleagues who are part of our network and that sort of thing, who are just fantastic at helping navigate my rambles and kind of try and prioritize, what should you do? How do you try stuff? And I mean, even some of the things is when we tell people, try medication, see if it feels better. It's feel better how? Everything feels terrible. So some of that is, how do we do that? So there's some of the apps like Guava and Visible. I'm trying to train my own AI, which I've nicknamed Durian, to try and help with that. So I'm still training it up, but hopefully to try and, because it's so tricky. There's so many symptoms. They can affect so many things, and then that also fluctuates. So did that intervention help or not? That can be really tricky. And again, that's where excellent EPs, physios, allied health, who generally have a bit more availability, can kind of help sit and navigate. So I rely on them very heavily. And also because I'm fundamentally a chaos goblin, so trying to order something is actually really hard for me. So I'm not great at it. I'm trying to get better at that. So yeah, very individualized. And again, you're kind of weighing up. It's I think maybe MCAS is driving a lot of this, but actually it can take a bit of time to get the MCAS sorted out. Maybe POTS is not their biggest problem, but POTS is pretty easy sometimes. So maybe that's actually something we can do quickly. And in that kind of allostatic load, okay, it's not the biggest piece of the puzzle, but I take that away, and now you've suddenly got more capacity for everything else. So there's quite a bit of negotiation and kind of strategizing. Yeah, what's possible. Cost is also an issue. So what can we do for the cost and access and timing, what's easy, what's most bothersome, and you're always kind of weighing up all those things to try and work out what's the best way in, what's the most powerful lever I can pull, or am I better off whacking 10 small moles because the big mole is too hard?
It's such an interesting thing to navigate, that idea of like, which lever do we pull? Maybe some things are easier, but not necessarily the big things. And I think that it's often something that I'm thinking about working in the pain space as well, is it's like
Oh,
you do sometimes have these big things that are contributing, but for whatever reason, logistically, they may be way harder or outside someone's capacity to tackle at that point in
yeah.
time. So it's like, cool, like where do we find that avenue in? If we can kind of reduce that overall load, it can make a big difference. And I think it's interesting. You mentioned the allostatic load and how if somebody's having maybe hormonal things going on, that can be influencing. And I think for those who are listening who aren't as familiar with the allostatic load model, we are planning on. I'm good. That's another episode we've hopefully got in the works coming up soon. But effectively, when we're talking about allostatic load, really what we're just describing is that our body's stress response systems has lots of really sophisticated ways to respond to and adapt to all the challenges and threats that our body is coming in contact with. And so whenever we come up against anything that could challenge our body's sort of safety or functioning, or threaten to knock us out of the ranges our body likes to keep itself in to keep operating functionally, we do get this sort of interaction between the nervous system, the immune system, and the endocrine system, our body's stress response systems. And they will work together to react to whatever we're coming up against in terms of stresses or challenges. So that can be external to the body, like environmental triggers, like we might see in MCAS, but it can also be stuff that's happening internally as well. So if we do have things like hormonal imbalances, or maybe there are other diseases going on, that can all, form part of that load. But what's really interesting, I think, is that one of the main ways that our body's stress response system actually responds to threat is through inflammation. And that's kind of what we're talking about with MCAS. And even with, POTS, the autonomic nervous system is really involved in that too. So we do see like all these things could be kind of getting all mussed up and interacting with each other and then influencing that. And I think we see that a lot in the clinic. I think most people you talk to, you'd probably hear, maybe they are having a period, yes, they might have MCAS going on, maybe they have POTS, maybe they are hypermobile. And when you talk to them, there's a lot of different things going on, but it's quite common. And, for most people, that if they have a really particularly bad week where maybe they've had a particularly stressful time, maybe they've slept like shit, maybe they have had other things going on that has placed stress on their system generally, maybe they've had a cold or something, unusual. We often see that you then get the flow on effect of all the other symptoms tend to be flared as well, even
Hmm.
though nothing else has changed. So there's just so much I think we don't yet fully understand, but it's really interesting to hear that. So yeah, I think that highlighting just that complexity, and it is often the combination of the medications, allied health input, dietetics, getting gut things under control, very person-centered sort of approach. And like I said before, maybe a pragmatic approach to, how is this person presenting and what are their main concerns, and where's our in. I think there's probably a mix of people who have been listening to this episode. We probably do have a mix of patients and health professionals. I wonder if you had one bit of advice that you could give to either patients or health professionals who might be listening, who are maybe working in this space, what would that advice be?
I guess it's going to be tricky because all the health professionals listening to this are already going to be part of the camp. I think, uh, believing your patient and their experience and appreciating that there's a whole bunch of stuff that we can't possibly know. To paraphrase Tony Abbott, no one's the suppository of all knowledge. So just keeping that kind of curiosity and acceptance that, yeah, we don't know everything. I get mad about. So I used to find that mug is like, don't confuse your Google search with my 6 years of med school. Like, we did 4, and 4 years is not very long for the entirety and the complexity of the human body and every disease process and individual. Um, so I think, yeah, having that kind of realization that we can't possibly know everything, and also you don't have to know everything, but believing your patient, and then kind of if there's resources out there. So if you're interested, there's resources out there, you can learn about it. There's a growing number of people who are interested, and so facilitating that kind of care onwards to someone who might be able to to help. Chronic illness sucks. I think we don't appreciate its suckiness enough in the medical space. I don't think we appreciate what a toll it takes on you, your relationships, the overwhelm. I am reasonably well educated. I kind of know my way around the system, and being in hospital and feeling that disempowered, being told that I was wasting their time, I have, by all accounts, a fair amount of power. And that happened to me. So, the experience of other people who don't have that, who've been repeatedly been gaslit, denied, I think is a huge indictment on our system. I think, believe in your patient, hopefully get inspired to do something, learn about it, or at least start the pathway. And then, if you're not comfortable, facilitating on referral to people who can. There's Facebook groups, there's Reddit, there's community groups. The allied health are miles ahead of the medical. So I know psychology, physiotherapy, EP, dietetics have all kind of come a lot further. So they'll often have excellent networks. There's various directories, Australian POTS Foundation, Emerge, EDS Society. For patients, I think I'll steal this from Larry Afrin. It's challenging, but it's also an opportunity to learn more about yourself and your own condition. And because it's so unique to you, you're going to be the expert. All of us are going to help you and help guide you with what we know, but ultimately it's your experience. And the other bit that he says, we can't cure it. The aim is to have you feeling well enough of the time. And that's a very personal threshold, and that can change over time. Just re-emphasizing just how much of a multidisciplinary sort of game this is. We need all the help we can get, reaching out and having a curated network of people who can help you as a patient or you as a clinician kind of manage.
Thank you so much for your time, Jason. I really appreciate it. I'm sure everyone who will be listening to this will be very grateful and appreciative for your insights as well. I'll definitely chuck in the show notes a couple of links and resources because I'm sure there will be a couple of people out there who are keen to learn more. So definitely check out show notes for those. And just want to say a massive thank you. It has been great chatting. Thank you so much for your time.
Thanks so much for having me. It's a pleasure.
If you enjoyed this episode, we'd love for you to share it with a friend or a colleague, or maybe even leave us a quick review. Don't forget to subscribe so you don't miss any future episodes. If you've got an idea for a topic or a guest that you'd love to hear, definitely send us an email at podcast@vivepainfatigue.com.au. If you're interested in more resources or information, head to our website where you can find out more about our clinical services and our professional education. Until next time, take care.